Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes. You'll also hear from Bent Brayman, our media and graphics design producer here at the Exam Room podcast. Bent brings over a decade of experience producing multimedia content in the healthcare space, including work with major organizations like the Core Institute and the University of Phoenix. From video production to motion graphics and audio storytelling, he's the creative mind behind how this podcast looks, sounds, and feels. And when he joins the conversation, he brings a unique perspective grounded in both design and real-world healthcare experience. Why are so many clinics still struggling to thrive in value-based care? In this episode of the Exam Room podcast, Dr. Rhiannon Winsor is joined by Shaun Romero, a healthcare executive and co-CEO of Medwest LLC, to discuss how rethinking workflows, integrating smart data tools, and reducing manual burden can unlock better care for both patients and providers. From EHR frustration to provider burnout, this conversation dives deep into how we can build better systems that support the people behind the care. Let's jump in.
Welcome back to the Exam Room, everyone. Today, we're speaking with Shaun Romero, an experienced healthcare executive and co-CEO of Medwest LLC. Shaun specializes in transforming healthcare operations through value-based care strategies, technology integration, and operational excellence, always with a focus on improving both provider satisfaction and patient experiences. Thank you for joining us, Shaun.
Thank you for having me here.
Clearly, value-based care holds a special place in your heart. Tell us a little bit about your personal journey.
It starts from, I think, primarily from my wife. She's a primary care provider. And getting to see the challenges that she has and what changes have happened over the last decade or so. And in primary care specifically, how it's just the focus is always to get to an endpoint of better quality, better care, but it moves so slowly that it just never seems to actually happen. It happens in pieces and parts, but not actually transformationally, where you have people jumping in and saying, I'm gonna do this because it makes the most sense. And so my journey really kind of started off with seeing from the outside what she's going through and understanding that perspective. Our medical clinic, jumping in as the administrator, understanding the nuances and challenges that come about with that process, I realized that you can make changes, but you have to take some risks. And I think that a lot of people are opposed to changing what they're familiar with. And so my experience really came about with me, jumping in and taking challenges and bringing them on and saying, here's what we're going to do because it makes the most sense. There's going to be some learning curves, but that's going to challenge me as well, and that's going to help me learn through this process. So that really is kind of what I started off seeing, is that there's this amazing system here with healthcare that's being underutilized, and patients are in a way disenfranchised from the quality, from the better elements that really they need. And the real setbacks to that are people who are just entrenched in just doing things, the business as usual. And getting outside of that is really, I think, what drives me. And continuously challenging my outlook and my insights on how I can improve. So that to me is kind of my personal journey, is realizing that there is a lot of good that you can do, but you have to be willing to jump in.
Yes, and change is hard.
Mm-hmm.
We in the healthcare field, and I think all of us just as humans, we're change averse.
Mm-hmm.
But that's how we grow and that's how we improve. Tell us a little bit about Medwest.
Yeah, so Medwest is sort of an idea that we used in our clinic. The workflows were basically the foundation of what we're doing with Medwest, which was we really wanted to jump into value-based care, but we realized we needed to have different workflows and different ways to optimize the way that we aggregate our data. Mm-hmm. And so with ClearPath Family Healthcare, which was our clinic, we really used a lot of the workflows that automated information from the HIE, patient discharge information, and put that together front and center for the provider at the visit. And so that kind of started the whole framework of what really excited me about value-based care and administrating at a clinic is that it really is the way you approach it. So Medwest took that whole philosophy, that whole methodology of how to approach the data, and in conjunction with SmartLink Healthcare, we use a system that basically is able to put that information in front of the provider and pull data from a multitude of sources. So we're really trying to make sure that we're boiling down the amount of manual effort in simplifying the data so that the provider can act on it in the visit with the patient without having to challenge themselves with getting that data beforehand. In our clinic, one of the challenges that we always faced was we were hit with different types of data sets, whether it was a Excel list being emailed to us, or we had to log into an HIE or provider portal. Managing that data, every single patient, checking every single visit was just too difficult. And in primary care, you're working with slim margins. There's not a lot of money to just throw more bodies at the problem. And so we had to really think about how do we do this in a way that gets data to the providers that they can act on, that they can actually, we get the throughput that we need for that patient to get better quality. And so Medwest took a lot of those ideas, the systems that we implemented at ClearPath, we helped refine them a little bit with SmartLink Health, and we put together a system that basically delivers that to the provider and automates the whole back and front end to get around these issues of data acquisition.
Wow. Yeah, I know as an ACO, VB Care is one of our jobs is to take that data that we get from the health plans and, kind of cook it down and give it back to our health centers. And, we partner with FQHCs. And so my question is, I want to pick your brain about what are some things, in your opinion, that FQHCs can start doing to be more successful leveraging these techniques that you talked about?
Yeah, I think that integration with FQHCs is one of the biggest challenges. Being able to utilize data that you have access to in a timely fashion is hugely important and challenging. So better integration systems, you need to have not additional layers that the provider needs to have access to, but you need to have everything boiled down into a simple format that can be digested and not have additional layers of people having to modify or access that in between. But federally qualified health clinics have another challenge, which is their financial alignment is, I think, it's almost in contrast to value-based care in a lot of ways. And so not only do you have the IT systems that you're having challenges trying to communicate with, but you also have the incentive alignment is a little off. So when it comes to IT systems specifically, though, I think that working with integrated partners that deliver information without additional staff is the first big step, and are not perceived as layers for the provider to do something extra. I think making it simpler is much harder to do, but that's ultimately what has to happen. It can't be here's another login, here's another thing you need to do, provider, with each patient, and not fragment the care. So every patient should really have the same workflow, because now if we have a multitude of workflows, every patient's different, it makes that near impossible to be successful and scale it long term.
Yeah, and when you and I were talking before, you mentioned about automating as many processes as possible.
Yeah, I think, and right now is a perfect time. I mean, we've a lot of AI, a lot of systems that can kind of communicate together. Now, AI is unique. There's a lot of robotic software. The software that we have partnered with is robotic software. It's been developed for over 20 plus years. But there's a lot of interesting things happening now where people can take advantage of automation and really kind of implement in the clinic and the practice to help offset that burden. But it really, there's been a lot of studies too that have talked about the time component to each patient's visit and the manual effort pre and post visit. And automating that, I think, is really one of the biggest things, is making sure the providers not just getting pieces of paper between each patient visit, letting them know, hey, here's one more thing to remember in the next 30 minutes for that patient, or here's something that wasn't completed that needs to be completed now. Those last minute type of data dumps and information overloads, I think, is really what needs to be automated to get that meaningful steps forward into a process that providers can operate in.
Yeah, I think that AI could really help with that. Some of those things. I know I attended a webinar not too long ago about an AI called Navina, something like that. But there were a couple practices that had employed it, and they were just talking about how much the providers appreciated that it was kind of a holistic view of the patient that they got in, a split second that could help them prepare before they went in to, see their patient.
I think I've heard of that system or one similar to it where it's almost like up-to-date version, but AI style. Yeah. Those are, I think, really unique. Again, there's so many different elements a provider needs to pay attention to for every single patient, and it's not all in one siloed in one area. There's 4 or 5 different sections, and they need to be looked at consistently. To put that all together in a concise way is very challenging.
Yeah, with everybody having like separate EHR systems too, and like none of that stuff has been like standardized at all.
Yeah.
It creates this like very unfortunate barrier that can make even automating some of those tasks very, very complex. And speaking to what you were talking about earlier when you were talking about layers, the least amount of barriers you have to like get the information that you need, the better overall experience is going to be for everybody.
Yeah, 100%. Sure. One of the early on things that we realized with SmartLink was they have a proprietary connection type called SDC. It's like an API, it's like an HL7 connection, completely compliant. It's unique in that it uses a user interface framework, so it can access the system like a person. And what we found very valuable about that was that we were able to get around the EHR vendors' lag time for integrations, the restriction on discrete data use. So we didn't have any limitations on what we could pull from the EMR or EHR. It wasn't limited by the market vendors that the EHR partnered with that they required us to go through in order to get more of that. So it gave us more control. And I think one of the challenges, and this is what made me passionate about it early on, was that it is so challenging, but there's a solution that's right there, but it requires us to kind of change our complete approach. Providers should have the access and the ownership of those patients' records in that sense. In order to deliver care the right way, there shouldn't be barriers to get key elements to that patient's care. So the whole EHRs fragmenting and keeping the data in their own silos and their own systems because it's financially beneficial to them actually pulls away from the care scenario that we're trying to achieve with value-based care, because it makes it too difficult. It's another barrier to care. And so that, to me, seeing that early on and working with SmartLink, realized, okay, we have to approach this differently. With smaller clinics, even larger clinics, every EHR integration costs money, and it's going to have another person who's trained to manage that new system on the clinic's end. And so overall, the cost is another barrier. And so it's not doing what everyone else is doing that is going to work. It's really finding a way to take ownership over that patient's data, be able to have great access and control over it, and then be able to operate off of it. And you can't do that in the current framework very easily.
Yeah, and from the patient perspective, nothing is worse than going into the office and the physician comes in to see you and it's like they're meeting you for the first time again.
Right. Or even worse is, oh, you know what? I can talk about that next time I see you. We'll schedule another visit so we can talk about what you came in today to talk about, but let's push that off until another time. There's no way to manage a relationship that way with a patient. And it does leave patients with the feeling like I felt like I was ignored, or what was important to me wasn't important to them, and I feel like I'm left out wondering what happened. So that's
Yeah, it was explained to me once, like way back when, like clinicians were taught to come into the exam room with what's most important to them, then also discover what's most important to the patient, and then work towards both of those things kind of simultaneously.
Yeah. And patients come in with a chief complaint, and the provider might have certain things that I need to finish this stuff today. We have to talk about this today. But they do have to pivot sometimes. In that chief complaint, maybe there's something new that's come up that changes the scenario. But either way, the patient is more likely to come back if they feel like they're being heard, and they're more likely to follow through with their care if they feel like it's in line with their expectations. So there's a very interesting play that goes on there.
There is. And I have one of my specialists that I see, and he is so great. Like, his bedside manner is so great. He's so personable. But I know that he's going to be late to see me, because he does that with all of his patients, right? So there's that trade-off there. Like, can this thing kind of reduce that and still give the provider the ability to be more, I'm going to use the word personable, and not, have me waiting for 45 minutes before he sees me?
Yeah. I think that the reason that you see that happen a lot is because there are a couple key challenges there. There's the incentives, whether the provider is doing a fee-for-service or they're really looking at the number of visits they kind of squeeze in per day. That in itself is just super challenging. So, and I've been to providers too where they're running late, and they're typically consistently late. Well, that's their workflow. They're going to double book. They're going to, have extra people scheduled because they know the no-show rate's going to be 16% or 15%. And so they want to keep it full. But at the same time, where is there really time for them to review with what's needed for every patient before the visit? And so it's a compounding effect where you've got a lot of people lined up, and you've got a lot of information that has to be looked at very quickly and briefly and before each patient. And so that just sort of perpetuates that same always late scenario. With a system where you're able to automate the acquisition of data and put it in front of the provider in a way that they're not having to surf around for it, can substantially reduce that. So in the system that we at Medwest use is really embeds itself in the EHR, and it works with 90 different EHRs. So it's pretty agnostic in that sense. It puts the information in like a ribbon, an actionable ribbon that the provider can click and drop into the note. And it doesn't require them to look at another pop-up and say, oh, okay, yeah, this is relevant. It just requires them to look at the note, talk to the patient, and see, okay, well, I see that there are 5 or 6 things here that we need to also cover, and they can drop it in the note. So with a lot of EHR systems, in order for a provider to drop a code, they're going to have to do search procedures and look in a list and then find the relevant highest specificity for that code and drop it into the note. It's a lot of time here. We're talking 10, 15, 30 seconds every single patient, 2 or 3 times a patient. And then we're talking about pre and post visit time. That adds up to sometimes hours per day, and definitely hours per week that the provider's either squeezing in between patients or they have allocated time. So the problem really is the presentation of that data in a way that the provider can digest it without them having to look around for it, really. So in the scenario that I like to paint a lot of times, if you're coming into an office visit, how unique is it and memorable if you're talking to the provider and they're giving you eye contact? They're not focused on the screen, and we've probably all been there where you've been in a visit and the provider's not really looking over at you, and you're like, they're looking at the screen, they're typing, and it's like, am I here? And so that feeling, to me, it leaves me with what did I gain from this? Other than I know I have to come in a month or 2 for a follow-up. Like, I feel like it just sped by. But if you have the opposite of that, where the provider's engaged with you and they're looking at you and they're like, well, I'm aware that you've got, and maybe they glance at the screen, you've got this and this, and you had a diagnosis that was done from your cardiologist last month. Tell me about that, And the provider has that information. It not only fuels that engagement with the patient, but it reinforces the relationship that, this provider is paying attention to me. They know what's going on with me. They have a really good handle of what my health picture looks like. And yeah, they're right. I need to follow up on this, or I need to come back in a month because this is information that is affecting me. And they'll have the ability to explain the reason why that's important, that they follow up on their care, or that they have a scheduled follow-up visit, and as opposed to looking at the screen and just going and checking the boxes in a sense. I mean, I've seen other systems that try to do a lot of the same, providing information in a way that a provider can look at it during the visit. But the problem is it's another layer. It's another login. It's another click. It's a copy and paste. This ties into one other element that I'm really passionate about, which I'm probably jumping around, but provider burnout. And so this is a self-perpetuating type of system where we keep adding more layers, and with the idea that this is going to make it better, and all it's doing is it's putting more distance between the patient and the provider in that visit.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.